I'm 100% agree with Dr. Ellen Bogan about IVM. I also want to expand IVM application for clinical ART. Okay, I will talk following these agendas. And the first, gametogenesis and the follicular development in human adult and clinical application outcome, and safety and advantages, and then final in summary. And as you know, the chronology of the gametogenesis, and for men, and we can make the sperm from puberty to almost till death. But for women, and they have the almost 2 million oocytes when they were born, but only 200,000 when they get puberty. And also, this continuously, every month, just one oocyte, mature oocyte, will be ovulated. And then until the menopause. So the very short time, and also the number is limited. That's why we need to do more IVM. And follicular development in human, you know, the Dr. Ehrenberg also showed the Goujon's criteria of follicular development. This is a kind of very simple slide, but if we classify to class 1 to class 8, that is a classification of Dr. Goujon. And also it takes about 85 days. Then when we see from the date of the 85 days, for IVF we use usually class 8 oocyte. This is mature oocyte, it is said. But IVM we use a class 6 or 7, and it is said it is immature oocyte. But if we see 85 days is 100%, and for IVM we use usually about 77.5 days. That is already 91% matured. So when you deliver the baby 40 weeks, the mature baby. But if you deliver the baby 36 weeks, do you call immature baby? No, I don't think so. That is almost immature, but the date-wise, a little bit shortage. The same way, IVM oocyte is not so really immature. A little bit shortage of maturation process. So, clinical application. Usually, follicular development will go this way, clockwise way, and we use a M2 oocyte for classical treatment. Yeah, but we cannot see it's really metaphase 2 or not. But when Dr. Edwards and Steptoe developed the ART, we can see mature oocyte under microscopy. Then, as Professor Ellen Bogan already told, 91, Dr. Cha started IVM, and Tronson used clinically IVM. We in Japan in 1999, we got the first IVM success. And then lately, even IVG, you know, for the frozen ovarian tissues, such kind of technology, we need even IVG. So the oocyte maturation-wise, we are kind of developing to counterclockwise. So, and also, if counterclockwise, we can utilize more number of oocyte. So the stimulation protocol, the Dr. Edwards and Steptoe used natural, and then developing the stimulation, full stimulation. But lately, again, a kind of tailored medicine, tailored stimulation, getting lower and lower stimulation. So the IVM is the next generation of ART. The IVM is different from a little bit conventional IVF, ovarian stimulation. The IVM, I call the ovarian pre-treatment. We treat with sometimes FSH and sometimes metformin, and then get oocyte, immature oocyte. Mature the in vitro, and usually we use ICSI, but some people use even the conventional IVF. Then transfer the embryo cleaved and the blastocyst. Either way, in Japan we also do 2 steps transfer, that we transfer first the cleavage one and then second blastocyst to embryos. Okay. And then usually 3 menstrual cycles the follicular growth need. Then IVF we use the class 8 oocyte. But for IVF the retrieval window is very short. We have to retrieve within for example, if the follicle reach 80 millimeter, we have to retrieve 2 days later. Okay. But for IVM, this class 6 and 7, from the size of the follicle, the retrieval day is pretty wide. So from the size of follicle, retrieval day is pretty wide. We usually retrieve about 6, 7, 8 millimeters. But at the same time, if we focus on the number of granulosa cells, that is much smaller amount. So we have to also think about the luteal support for IVM, not only endometrium thickness and also the luteal support. For IVM, usually PCO patient, this stage is pretty long. So for IVM, the wide oocyte retrieval window, that is actually the benefit to not only the patient but also the physicians. It's very easy to be flexible for setting the retrieval date. So this is the history of ART. First IVF by Dr. Edwards, and this is actually Japanese first IVF 1983, and then this is somebody knows Dr. Takahide Mori, my mentor, and he started 1985, and then ICSI, that actually widespread all over the world by Palermo, and then Brussels transfer by Gardner, and then IVM in 1991 by Dr. Cha in Korea. And they treat not only IVM and also the PGD, PGS is also the modern art technology. At my clinic, new patient, we use not only IVF and also IVM as a first choice of ART. So we usually, for the PCO or PCOS patient, apply IVM for the first choice if patient accepts. So of course we offer 2 IVM or IVF, and if patient pick IVM, we do IVM as a first choice. Actual step of IVM is we get the immature oocyte and then mature the in vitro, and then once matured do IVF as same as conventional IVF. This is the IVM or not. You can see the process of maturation. Okay, that sounds very still process, but very active. This is maturating, and then this will extrude first polar body. See, this is not so simple. This is very active. The difference of IVF and IVM. IVM usually leads to no stimulation. Then we get the GB oocyte. Our goal is GB to get GB oocyte. IVF, more stimulation, short, long protocol or antagonist, and then get metaphase 2 oocyte. What is the difference? For IVM, the very little amount of estradiol is provided. So usually endometrium does not grow well. So at the time of retrieval, the less endometrium thickness. But for IVF, enough estradiol, so the ample amount of estradiol for endometrium, so endometrium thickness is enough. So from that point, we made this protocol. Somebody already asked, when endometrium thickness is less than 8 millimeter at the time of HCG, more than 8 millimeter, we transfer fresh. But less than 8 millimeter, we freeze 2PN or either cleaved stage or blastocyst. We freeze first, then subsequent cycle we transfer in frozen cell cycle. So by this strategy, we can apply IVM in any patient. And you can see this is the compare the growth of the okay, I wanted to move simultaneously. But this is IVM embryo, and this is started simultaneously. Okay, IVM embryo and IVF embryo. See, you can see the speed. They will grow almost same time. Okay, nothing different. And also, this is still the blastocyst. By time lapse, they grow almost same speed. So usually it is thought, IVM embryo is less well than IVF embryo, but actually they grow almost same time. Yeah. So both reach to the blastocyst stage at the same time. See, nothing different. So our way of the correction of oocyte is we use a 2-needle system, one bigger needle and also smaller needle, like this way. And the first we puncture the ovary by bigger needle, and then hold. There is a file formation here. Then hold the ovary, and then insert the smaller needle inside the outer needle. Then puncture the follicle by smaller needle. And similarly, just rotate the ovary and then puncture another needle. Just puncture once by bigger needle and then puncture one by one, changing the direction. Then aspirate, same way. And first check the vessels by color Doppler, and then puncture the follicle by small needle, like this way. The 5-6 millimeters still we can retrieve the oocyte. This is the actual scene of the there's the monitor here, this side, and then puncture a little bit just by snap, using the snap, and then rotate the needle, like this way. Then flush the needle each time, otherwise that blood clot will, stuck in the needle. And the outcome. And this is the indication, so this already you know this. And then this is the last 11 years. We have done every year about 55, and then pregnancy rate, clinical pregnancy rate is about 28%. This is for 11 years record. And then when I focused on the pregnant cases, then fresh cycle 94 and frozen cell 44, and then more PCO. in the fresh cycles. And then average age is no different, and age median is no different. Okay. This is the estradiol, the day of HCG. This is for fresh cycle, about 200. Median was about 100. And also the frozen one, and estradiol was about 100, almost half. And then median was 50. But if you see the estradiol level, okay, from 18 to 3,000, this is maybe some stimulation was done, and this is 10 to 700. Even 10 estradiol, 10 picogram, we can get pregnancy. This is menstrual cycle day, NOP. And for fresh cycle, about 15 days. And then frozen cycle, about 13, 14 days. Median was 15 and 12. So more day we need for fresh and less in frozen. And also this is interesting. This is 33% of the cycle days, because for IVM, some patient is 60 days cycle, some patient sometimes 90 days cycle. So this is percentage wise. So if 60 days cycle, that means about day 18 for retrieval, and then day maybe 15 for frozen. Okay, so it depends on the patient day cycle. So this is important, and also this percentage is also very important. So this is not only the date. If all patient 28 days cycle, this is important, but this is more important for IVM. What percentage of the day? So this is a kind of, we recommend the protocol for fresh transfer IVM, endometrium more than 8, and then estradiol maybe more than 100. And then day 17, but it depends on the cycle date. If patient 40 days cycle, day 14, 60 days cycle, day 20 is good for retrieval. For the frozen cycle, usually less than 8 millimeter, and then estradiol more than 50, and then usually day 12, but it depends on the cycle date. So if 60 days, day 17 is okay for the retrieval. And then IVM for the repeated IVF failures, and we have done the IVM for repeated IVF failure. At that time, the previous 4.7 times IVF failure got a pregnancy by IVM, average 3.4 times. Okay, fresh cycle and also frozen cycle. So this is the red bar is the failed IVF cycles. This patient 15 times, 14 times failed IVF, and then first time IVM, she got pregnancy. That also happens, you know. So some patient more IVF, but very little number of IVM. Some patient failed IVF and then changed to IVM, takes a little longer by IVM, but still get pregnancy. Why they move to IVM? Some patient by OHSS, embryo quality, and ovarian reserve, poor patient, and also some patient for the empty follicle syndrome, we can apply IVM. And then successful type for fresh, as I showed before, the PCO patient, and frozen half and half. So either way you can do. And safety of IVM, and we analyze the patient and 86 babies, and boy and girl, and this is not different. Okay, that we followed the 55 babies. Okay. And also, this is the chromosomal abnormality of the abortuses from usual IVF and also IVM. We usually apply ICSI for IVM, so compare usual ICSI, fresh and frozen ICSI. This is abortuses, abortion, really sampling. And so then average, nothing different. So even abortuses, nothing different. Okay? And also the number of chromosomes, that this is usual IVF ICSI and IVM, the same part. So nothing different from IVF. So the same numbers of chromosomes are affected, either IVM or IVF. So advantages of IVM. And for IVM or IVF, the same part, changeable. But this process is unchangeable for IVF, but changeable for IVM. So we can utilize this part for the benefit of IVM. So we use IVM for the patient to save some embryos by freezing and then transfer at once. So the IVM protocol is whatever we fail, we can move to IVM. Of course, for the PCOS patient, we will apply first IVM. And this is the case. And she got frozen embryo transfer by IVM and failed by IVF, but got pregnancy by this patient got fresh transfer IVM and the pregnancy. This patient, they are poor quality embryo by IVF, but got pregnancy by IVM. The same way they're fresh and frozen, and they did not have the transfer by IVF because of poor quality of embryo, but they got pregnancies by IVM. In summary, and the women's oocyte number is limited, and then IVM is not so really immature, and we can use some clinical way, and then we can do something by culturing the immature oocyte. And IVF failures can get pregnancy by IVM. IVM is very safe, and this is a kind of pragmatic protocol for IVM. And then we can see the place of IVM in this diagram. And I can say IVM is the ultimate IVF light. So good for the patient and maybe good for even financially. Thank you very much for your kind attention.